I watch these videos as an insider, and every single time there's something new, there's something different, there's something even more inspiring. And the previous video that played before Carlos' session, we were backstage and I almost choked up. Mm-hmm. So these are real. So here's the deal. So we saw Suzanne. There's obesity, there's cardiometabolic health, there are comorbidities, there are serious illnesses. And what they may all share in common is their association with weight and the accompanying molecular and cellular level changes. Last year came GLP-1s with a bang on the weight management scene, and we're all still reeling from the impact. Many of us had to make very dynamic, iterative decisions about treatment, cost, coverage, and what have you. Turns out that the methodology of action, the mode of action of these drugs is at best complementary to lifestyle management. It's not a panacea. No one size fits all. There are patients who respond remarkably well, and there are some that barely respond. Some have significant side effects, some don't have any. Some stay on for 12 months, some can't even stay on for 12 days. And there are new drugs in the pipeline, right? So here we are. So where are we? What are we learning? Where are we headed? Are just some of the things that this panel is going to explore with the help of 3 esteemed clinicians from very different organizations. I am Vidya Raman-Tangella. I serve as a Chief Medical Officer for Teladoc Health. And in that capacity, I have responsibility for our cardiometabolic health strategy and solutions. So with me, I have Dr. Shealynn Buck, who's the Chief Medical Officer of Lockton Company's U.S. People Solutions, and she's the physician leader for clinical strategy and informatics. She has over 20 years of experience in healthcare strategy and operations and is co-chair of Lockton's interdisciplinary clinical advisory practice. Welcome.
Thank you.
Dr. Robert Gabbay is the Chief Scientific and Chief Medical Officer for the American Diabetes Association, which is the global authority on diabetes. Dr. Gabbay leads the ADA's efforts to drive discovery within the world of diabetes research, care, and prevention. Dr. Tim Law is the Chief Medical Officer and Vice President for Integrative Care Delivery at Highmark. He's a board-certified physician with over two decades of clinical experience and has been instrumental in Highmark's journey towards virtual health and digital therapeutics. So thank you all for joining me. Dr. Gabbay, I might start with you. I recall 15, 20 years ago, you could almost draw a straight line from calories consumed to body weight, fat consumed to body fat. Oversimplification, but that's what it was. And then we saw more science emerge around carbohydrates. Then it wasn't just the quantity of carbohydrates, it was quality of carbohydrates. It's the timing of food. It's the combination of the various macros. So when you eat carbs with protein, fiber, or fat, slows down the spike in blood sugar and hence the insulin spike, on and on and on. So science is constantly evolving. We're also learning a lot more about the role of nutrition, not just in cardiometabolic health, but musculoskeletal health, neurological health, immunological health, cancers, and so on. So why don't you get us started? Demystify the science. What is true? What is science telling us? How should we be thinking about obesity and cardiometabolic health?
Well, it's a great question, and thank you for having me here. So to start, it's really the recognition that obesity is a disease. And that seems on one level obvious, and one level, what's the big deal? And the big deal is that therefore it needs to be treated as a chronic relapsing disease. And that has implications when we think about how to treat it, because you're going to need to sort of have some type of, in many cases, lifelong intervention. And that's an important consideration. These new medications have really revolutionized care, and you can all appreciate this, but I'll just give you a little bit of the historical perspective. For decades, we maybe had medications that would give 5 or 7% weight loss. They had a bunch of side effects. They really weren't well tolerated or used very much. And then the GLP-1 class of drugs became available. Initially, an earlier version, these drugs have been around for more than a decade. They actually come from a discovery from the saliva, the Gila monster, if you can believe that. So it shows how like basic science things can actually turn out to be pretty important. And what they do is a few things. One, they slow down the emptying of the stomach so people feel more full and therefore eat less. And they also have actions on the brain to decrease appetite and hunger and what some people describe as food noise. And the most remarkable thing about these medications was really discovered by accident, that they lowered the risk of cardiovascular disease. This was really, all diabetes drugs were required to do a cardiovascular safety study before they could be approved, and a whole bunch of them, safe. And this one came out, and I was literally in the room when, big auditorium when they announced this, and there were gasps in the audience because there's a dramatic reduction in heart disease, which is the #1 killer for people with diabetes.
Thank you for that. That's awesome. To both of you, I'm going to call you Tim and you Shealynn. I can do Dr. Buck, Dr. La, and keep
great.
at it. So we'll do first names. You have very critical roles in the organizations you're part of. You are that strong clinical voice that first and foremost brings the patient perspective into conversations and helps the organization make critical business decisions, including about GLP-1s, right? And there are many people like you across employers, plans, and other organizations. Yet, employers and plans get demonized when it comes to the conversation about GLP-1s. So we'll start with you, Shealynn. Tell us a little bit more about your role. How do you influence the people that you work with? And what should we be saying to the people that demonize these roles?
Well, first, I'd like to thank you and thank Teladoc for hosting this conversation, because these are the types of conversations that we need to be having. So why Lockton? So Lockton is a consulting firm that is hired by employers to be their trusted advisor in making smart decisions about their people and their business. And so we have this interdisciplinary team of clinicians, population health specialists, clinical informaticists, all working together to help employers solve their toughest health and healthcare challenges. And there is nothing tougher as of late than helping them to address obesity, cardiometabolic conditions overall, and then obviously GLP-1s. So why are employers important to the conversation? I mean, there's been so much noise out there that the employer's voice has kind of been lost. And to your point, if it has been heard, it's been a bit demonized, like all they care about is cost, and that's not true. We are working with employers every day, and what they care about their people. And they just want to make responsible decisions. And so the employer is important to the conversation because over the majority of Americans, so over half of Americans, get access to health care through an employer-sponsored health plan. And when you look at those less than 65, it's 60% of Americans. So the employer channel is a critical channel for getting access to health care and also for addressing responsible coverage, quality, cost effectiveness. And so the employer, and you look at GLP-1s for obesity in particular, and Goldman Sachs has estimated that over 70% of the patients that would meet the criteria for these medications sit within an employer-sponsored health plan. So that alone tells you that employers really are having to pay attention and are looking to clinicians like us to help them make those balanced, responsible strategies around these types of issues.
Awesome. Thank you for elaborating. What about you, Tim?
Well, I'm sorry, but I can't remember the question because I'm stuck on the Gila monster thing. So let me
Don't
just
salivate.
a quick piece of advice. As a former veterinarian, please don't go out and kiss your next Gila monster. There are a lot of bacteria in that saliva. And number two, I can vouch that I've never seen an obese Gila monster. So
love it.
Having said that,
This was so not part of the
that was
prep.
so not part of the prep. Yeah, I will be ostracized from this stage after this. But anyway, the point, so at Highmark, yeah, we're in a unique situation here. We're a blended health organization, and while on the clinical side, we certainly have this, this responsibility to make sure that we're acting as conduits to appropriate care between our physicians and our members, their patients. We also have this fiduciary responsibility. So when we look at disease states, whether it be diabetes, obesity, heart disease, other things, we're looking at what the total cost of care is in a patient, not just this one episode. And so when you talk about a drug or a $3.1 million one-time dose of Elevitus for Duchenne's muscular dystrophy versus $1,200 a month for how long? The rest of your life, 1 year, 2 year, whatever it is for one of the GLPs, then you have to start thinking about where in the continuum does that fit? And so we like to meet with our employer groups as well as our fully insured groups and say, hey, this is what's out there. We can help you on the clinical side to tell you, is it working? Does real world evidence match what happened in vivo in the labs? And give them advice on whether or not that's something that they need to offer or not offer. There are a lot of things, and we'll get into it later, but it's not just a panacea where you take a shot and all of a sudden you're a different human being. That's not what it is, and I think we'll talk about that to come. But yeah, so at Highmark, I love what we do there because it's such a collegial atmosphere between us, the doctors and members, and we have them all sitting at the table. Back when these first started, I can remember that after about 2 months, everyone was worried about the cost, and of course the people that are counting the beans are saying what's the cost. And early on, and it's not the same now, but early on, we had over 85% of our prescriptions for that were written for diabetes. Of the other 15 to 17% that were written for obesity, 95% of them were written by our bariatric surgeon center. So in places that had full-scale lifestyle modification, support, mental health issues, all those kind of things were addressed. It wasn't just, having someone mail it to you in the mail and you take it and try to figure out what the side effects and where your next step is.
Yeah, and I'm sure you're going to elaborate on that a little bit ahead. But that's the dilemma, right? So we all know clinically there's a role. This is definitely an important tool in the toolkit, and it has to be considered alongside other attributes and such. There's a lot of, the beauty is at this present time, in addition to the scientific advances, we're also seeing a lot of real-world evidence emerge because for weight loss, it's been used for about a year or so. There is, for instance, a large data set that recently came out that shows that 50% of people, almost 50% of people will discontinue within 12 months when they're taking it for weight loss, right? And then the need for supplemental, so for instance, the sarcopenia, so the loss of muscle tissue that occurs, and the fact that you have to now supplement these other ingredients in the diet, all of these is emerging. And at Teladoc, we're not only tracking these macro level, but also trying to understand at a very granular level, like who's responding, why they're responding, who's not responding, why they're not responding, so that we can better do things ourselves and be in a position to work with others. We're also particularly interested in underrepresented populations, I'll say like women in the reproductive age, women dealing with polycystic ovarian syndrome, post-bariatric surgery weight gain as a side effect of other drugs, and so on and so forth. We also are very keen on the health equity aspects. How do we make sure that things, social drivers and other elements don't get in the way of people who really need this drug getting it. There are also a lot of questions that are being asked about how long does one stay on the prescription? What is the mode afterwards? Do you decrease it? Do you supplement with another weight loss drug? Like, what is that? A lot of people will tell you that it's had positive effects on their mental health and well-being. What about that? How do we take that into consideration? And then as a society, we went from body shaming to body positivity. You had Oprah on the board of Weight Watchers, then going on the medications herself, and recently saying, what is the point of Weight Watchers? So there's a lot to grapple with. I know you are collecting a ton of data, all of you. So talk to us a little bit about what your data is telling.
Well, that's actually been one of the joys of participating in this panel and other similar conversations, is we actually, prepping for this, have been able to share data from our different experiences.
And just so you know, prepping was last night driving to dinner in the car. So that's where much of the conversation happened.
Well, and we're going to be sharing some additional data after because it's just so important. But yeah, I mean, the whole point is this: the word real, or the phrase real world experience is critical. If we do not continue to study the real world experience with data and share that, we are going to, we talk about panacea, this will turn into a Pandora's box. Right, and so some of the real world data that we're seeing within employer health plans, and we looked at a data set of just over 880 self-funded employers and 4 million lives, health plan members, and we're seeing the same thing around discontinuation. So just over 60% of folks that start these GLP-1s for obesity are off the drug within a year. And of course, to the employer, that's sunk cost because the weight gain, they regain that weight. And so you lose not only the health benefits, but also the financial benefits. So that's been one of the big real world aha moments that we have. And I know that you both have seen that too.
Yeah, and we've been trying to tease out, so what is the discontinuation? And I think some of it is addressable, and we've been working with healthcare professionals. So setting expectations for the individual, because you slowly escalate the dose, you're not going to lose a lot of weight in a couple of months. You'll see almost nothing, and many people use it a couple of months and go, "Wow, this stuff didn't work. I'm the same." So that's one important piece. Being sure to slowly raise the dose so that you sort of mitigate side effects. Because if you start at a top dose, people are not going to do well. And then the other thing, I still see patients, and one of the things I always advise, because it works by slowing down the emptying of your stomach, people need to eat a little slower or take a little break halfway through the meal. Because what you can do is you can just put all that food in really quickly, and then the brain catches up, and you're like, oh, I feel terrible. And then people stop the drug. So I think there's some addressable things that we can start getting those messages out to ensure that sunk cost is not lost.
Yeah, well, what you're getting at is also personalization, leaving it up to the patient and the physician to have these conversations. Tim, what would you say? What's your data telling us?
Yeah, so very similar. We our own internal data very much matches Lockton. We have about 60% stopping rate by a year. But more importantly, I think, and where the financial piece comes in is what Doc just said here, which is we show some stuff from the BHI, the Blue Health Initiative, that shows anywhere from 20 to 40% stop within 6 weeks. So 6 to 8 weeks.
Yeah.
So you've already bought a couple of pens of it or whatever, and then you don't even continue. So you don't even get the benefits. And whether that be from starting too high, availability of the drug, co-pays, high cost deductibles, high deductible health plans, et cetera. There's a lot of issues that go into there. Until we really get to the bottom of why people are stopping it so quickly, we need to then be more diligent about how we can help doctors pick the right patient. Just like a spine surgeon, what's the best outcome for a spine surgeon, picking the patient you're going to be able to help, and that's what we need to be doing. At a recent talk I gave last month, I had 3 provider physicians on the panel with me, and to a T, every one of them, I offered them the opportunity to let them make the decision on who got the medication and keep the insurance company out of it. And they said, no, you be the bad guy. They wanted us as the insurance industry to say who could and couldn't take the medicine, which flies in the face of everything I've done in my whole career as a physician. I still see patients today. I don't want some insurance company being a roadblock. I want them to be a conduit to care, to give my patient access to me as a physician, and give me the autonomy to be able to pick and choose which patients need which medicine the most. And then that, doling it out to who needs it, et cetera, we can figure out later, but that's...
No, well said. Quick question, compounding pharmacy and GLP-1s.
Who wants to take that?
Who wants to take that?
I mean, it's scary, right?
There was a company in the news not too long ago for going not with the best provider for compounding. Bob, do you want to take it first?
Yeah, this is an area that we've really been leaning into at the American Diabetes Association as a protection to the public. You sort of don't know what you're getting. And you know, I was riding the New York City subways, and there was like a big ad and a pen that was like their own design pen, and who knows what's in there. You know, I think as we've been digging in deeper to the sort of issues around this, it's gotten to be hard even for the FDA that has limited power to be able to do much. And now there's an international component. So the compounding is happening from other countries coming into the U.S. So it's tricky. It's concerning.
Yeah.
It's even deeper than that. I recently was on a website. I do a lot of MMA ring doctoring stuff and work with a lot of bodybuilders, et cetera. And there's websites out there where they can get these peptides you've heard about, I'm sure, SARMs and SERMs, et cetera. And now they have the glutides on there, and they come lyophilized, and they send you a vial of sterile water, and they give you a little about 20-second video on how to mix the stuff and give yourself your injections. And it's called research product, so it's not considered a prescription.
So yeah.
Well, and I don't know if anybody saw the South Park episode on End of Obesity. That right there is our opinion of compounding. But you know, in all seriousness, you talk about the provider and the patient relationship. Well, we're seeing these companies that are disintermediating that relationship by going directly to employers and pitching these, you know, these telehealth / compounding pharmacy products that then, and they're saying this is a lower cost option for your people. And it may be a quick, I don't even know if it's a fix, but it may appear to be a short-term fix, but to your point, Dr. Gabbay, it has long-term implications. So we at Lockton, with our interdisciplinary team of clinicians, are advising employers to not adopt one of these compounding pharmacy strategies.
And I would just add, you know, the other part of some of those, I mean, I think there's some groups that are offering responsible care, you know, and all of that. But there's some that really is just, you know, call this number or go to this website, we will prescribe, without understanding the whole patient.
Right.
And that's
It's
always
scary.
when you get into trouble.
It is scary. And yeah, I mean, it's just a lot of gray here. Let's also quickly touch on a couple of things. One is, you know, the, what should I say, the strong role that lifestyle management plays in overall sustainable, optimal health. So there's that aspect. Then, the fact that these patients may not just be dealing with weight and type 2 diabetes, but may have other comorbidities. So when you think of treatment with GLP-1s, let's widen the aperture. How do we incorporate these elements into the picture? Maybe just a quick, like...
It's whole person. I mean, Teladoc was at the forefront of moving from managing a disease to supporting the individual that has this condition and all the other conditions that they have with it. I mean, when we look at our data with folks with type 2 diabetes, over 88% of them have another chronic condition that they're managing. And I would take it beyond the whole person, which I know is a bit of a buzzword now, to the whole family. I mean, we're talking about addressing things like food insecurity and addressing changes in behavior that have to accompany this comprehensive approach to obesity prevention and management.
Perfect.
Yeah, the lifestyle piece is important because it's a little reminiscent of when statins for cholesterol first came out, and people are like, wow, I could have like a double cheeseburger and fries and my cholesterol will be fine. And so the same thing is happening now with these medications, because people will lose weight and they can eat, you know, in a sense, what they want and still lose weight. And so I think what we're going to see the big shift is, for most of the time in terms of weight loss, it's been about the quantity of food, and the medications largely handle that for most people. So now we have an opportunity to really talk about the quality of the food. And I think that's going to be a big shift, whether that's more protein because of muscle wasting, or just reinforcing the value of lifestyle. And then, of course, exercise. If you could have a single drug and a pill that was as powerful as exercise, it would be the biggest blockbuster ever.
Well said. we should probably end the panel right there.
But we have to hear from
Yeah, we
Dr.
have to hear
Law.
from Tim.
I'm still thinking about the Gila monster. So a couple things. I think, we talk about personalized medicine all the time, all the genetic stuff out there. This needs to be a form of personalized population health.
Yes.
And we need to get that thought process ahead.
Yeah.
But in all the things that they said, all the diet, exercise, lifestyle modification, but really the part that I never hear anyone say, and I think it's part of Teladoc's cardiometabolic process as well, which is the mental health aspect of it.
100%.
You can't expect
Absolutely.
someone to go from being a 45 BMI to a 25 BMI and then look in the mirror one day and all of a sudden see a different person in front of them. And how do they now react to the world, and how does the world react to them, and who's helping them through that? It's not just simply handing someone something to give themselves a shot and saying, go out and exercise and eat less bacon or whatever. You have to actually, get in there and find out, how are they viewing themselves? Because that's how you end up back where you were.
Yeah.
Because you didn't recognize the person you start to see in the mirror.
Couldn't agree with you more.
Absolutely.
Yeah.
Let's maybe spend a quick second imagining. So science has evolved a lot. Where do we think science will head? Like what's lurking around the corner? What sort of decisions might we be forced to make?
Well, yeah, I mean,
Imagine.
this scenario follow really closely. So last month we had the American Diabetes Association meeting, like 11,000 people, huge sort of diabetes meeting. And obesity clearly a big theme, and two big areas. One was the pipeline. So there were literally 20 compounds in clinical trial results that are in the pipeline that will be, a subset of them will be available on the market. The hope is that will help address the cost. Now, that doesn't always happen. Insulin is the poster child for that, although now finally we're making progress there. So there is the pipeline, and then there are the new potential advantages of this class of drugs and what it can do. And so now kidney disease firmly demonstrated to reduce the risk of kidney disease. But there's also data on sleep apnea.
Yep.
Which affects 80 million Americans. And if you're an employer, that is a somnolent employee that is not going to be very productive. We have no medical therapy for sleep apnea. There's early evidence around Alzheimer's, addiction disorders. Parkinsonism, right, exactly. So it's really widening the opportunity for where these medications could have an impact.
It's very encouraging. Tim.
I was just going to say, but because of that pipeline, it makes it hard to be fiduciarily responsible to your company, right? Because we saw the big blip at the beginning, and then things came down, and then Zepbound came out, maybe 20% cheaper. So, and then there's another big blip. So if we're trying to predict what our cost is going to be of care of that for the next year, when we're trying to come up with rates for fully insured, ASOs, whatever, it's hard to predict where those blips are, because if this pipeline slows down a tad and doesn't happen, then you're going to overestimate how much the cost is. If the pipeline starts popping a new one in every 2 months, you're going to have all these blips, and all of a sudden your cost of care is going to be 3, 4, 5, 10 times higher than what you expected. So it's hard for the industry on both sides, for all sides, for the doctor, the patient, and as well as the industry itself.
Anything to add, Shealynn?
I think the future is beyond BMI, that obesity needs to be addressed like the complex condition that it is, in a comprehensive, holistic way with an interdisciplinary approach that it deserves. And that's what we're hoping to see in the future.
That's awesome. Really well said. As you all heard, and I think as we've been talking to each other, there's just way too much abstractness with the space. There's more nebulousness than there is concreteness. Things are evolving on a daily basis, and people are having to make decisions on a daily basis, patients, physicians, organizations alike. And so I think if there's one thing we can all do is band together, come together, share our learning, share our insights, so that together we can create those care models that address quality, safety, access, and certainly costs. So thank you all for being wonderful panelists and for this great discussion. Thank you.